Hello, I am Daniel Xibille, and I am a rheumatologist in Cuernavaca, Mexico. And I'm presenting the work that we have done over the past year regarding the use of baricitinib and tocilizumab for the treatment of moderate to severe COVID-19 in patients that were hospitalized at our center. And this is a collaboration between internal medicine, of course, Dr. Marisol Hernandez, Baldomero Flores, and two rheumatologists, Sandra Carrillo and myself, on the analysis of, well, basically the database of patients that we have seen over the past year and a little bit more than a year. So we all know that SARS-CoV-2 infection and COVID-19 associated pneumonia are characterized by this cytokine storm and this very, very dramatic response or immune system response to the infection. So from the beginning, we had the opportunity of, after seeing some of the literature that was coming out initially, of obtaining baricitinib and tocilizumab for a limited number of the patients that were hospitalized in our center. So we had a cohort of SARS-CoV-2 infected patients who had pneumonia and had to be hospitalized basically because of the oxygen requirement. And we analyzed the data from that cohort. And all of our patients had a positive RT-PCR test for COVID-19 or for SARS-CoV-2. And we collected demographic data upon admission. One of the aspects that we distinguished was whether the patient needed any kind of assisted mechanical ventilation. And this includes, of course, intubation, but it also includes non-invasive assisted mechanical ventilation. So in patients that required or not assisted mechanical ventilation, depending on the severity, on the clinical severity of their case, we opted for the use of tocilizumab at a dose of 400 to 600 milligrams in 2 infusions. The first one was at baseline, and the second one was after 3 days, or baricitinib 4 milligrams a day for a maximum of 14 days. This depended because patients tended to stay for sometimes shorter periods of time at the hospital and sometimes for longer periods of time. But the mean time the patients received baricitinib was approximately 7.2 days. And the outcomes that we took into account were the need for assisted mechanical ventilation if the patient had not required intubation or CPAP initially and then had to be ventilated, or if the patient died or was discharged either because they improved or because they were taken to a convalescent clinic which took care of patients that had milder symptoms after treatment. And of course, we considered a P of less than 0.05 as significant. So we analyzed the data from 733 SARS-CoV-2 positive patients. Most of them, 65.3%, were male. The mean age of our patients was 58 years, ranging from 18 to 94 years, and the standard deviation was 15.1 years. 61.3 patients had one or more comorbidities, and the combination of diabetes and hypertension, as well as isolated diabetes or isolated hypertension, were the most frequent comorbidities that we saw in our patients. A third of our patients had either diabetes or hypertension. Around a quarter of the patients, 24.3%, had a history of smoking or previous smoking or current smoking, and 18.7% of patients required, that's 137 patients, required assisted mechanical ventilation. 23 of these patients were treated with tocilizumab, and 36 were treated with baricitinib. Of the patients that were treated with tocilizumab, 9 of them, which is 40.9%, required assisted mechanical ventilation, and 17 of the patients that had received baricitinib required assisted mechanical ventilation. So 40.9% of patients with tocilizumab and 47.2% of patients with baricitinib eventually required assisted mechanical ventilation. Those patients that used tocilizumab, they correlated with a reduction in the need of assisted mechanical ventilation. So less of the patients that had received tocilizumab had to undergo intubation or CPAP, and this was a significant correlation. 12 of the patients that used tocilizumab were discharged due to improvement, but 10 patients that received tocilizumab eventually died. And in the case of baricitinib, 25 patients were discharged and 11 patients died. And baricitinib had a better correlation, a significant correlation with lower mortality. So this was the main observation from this this paper, and you can check the poster afterwards. So the evidence here was that both tocilizumab and baricitinib play a role limiting inflammation in COVID-19 through, we suspect, the inhibition of IL-6 mainly, but probably through other mechanisms in the case of baricitinib. And their use was justified in cases of severe COVID-19 in a hospital setting. The use of tocilizumab was associated with a reduced need for mechanical ventilation. We preferred to use tocilizumab in patients who were already intubated because it's easier to administer this drug. It's intravenous as compared to baricitinib, which is orally administered. But patients who received baricitinib and were discharged due to improvement were significantly higher than those treated with tocilizumab. This could be partly due to the fact that patients who received tocilizumab were more likely to be intubated than those that received baricitinib. So that is one of the study's limitations. And the study is also limited by the fact that it is a small number of patients, although it might sound like a lot. It is a limited number of patients. And the other thing is that evidence for the use of baricitinib is in combination with remdesivir, which we did not employ in our case because we didn't have it available. So the take-home messages is, I would say, are mainly we have options for the treatment of severe disease, tocilizumab and baricitinib. Tocilizumab is a good option for those patients who are intubated. Baricitinib is more practical for the use in patients who are not intubated, and a reduced need for intubation in those receiving tocilizumab prior to their need for assisted mechanical ventilation is seen, and patients will probably be discharged earlier if they use baricitinib. But of course, we need more data in this sense. So thank you very much.